With an INR of 2 to 3, based on a couple of studies that had numbers in the hundreds. I want to say 114 and 170, but I'm not entirely sure yet. But let's call them rather small numbers, showing that, in fact, if you look at strict outcomes of recurrence of major thrombosis, aggressive anticoagulation right away is no better than normal anticoagulation. And okay, even that, let's accept it as true, but they make no mention of symptoms. There is no mention of symptoms of Hughes and phospholipid syndrome on the guidelines of the British Society of Haematology, whereas rheumatologists, and this might be because Professor Hughes is a rheumatologist, they will look at symptoms. And here's an example of it. One of Prof. Hughes' patients who gave him permission to write about it in his books, she would do the Times crossword every day, and every day take her INR for a year. And then she plotted it all, the time taken to do the crossword and the INR on a graph, and it was linear. The higher the INR, the quicker the crossword. I was talking with Dr. Sangal, another author of several books and part of the team at guys at St. Thomas's and world expert on phospholipid syndrome. And he was telling me, do you know what? Sometimes patients come to A&E because they're bleeding and the INR is sky high, like 9, 10. And you ask them, okay, but other than the bleeding, how are you feeling? And they say, never felt better, doctor, because it's true, the higher the INR, the better people will feel. Which also means that we can't forget the possibility that people might intentionally take a little bit more sometimes. Presentation has, sorry about that. Okay. Sorry about that. Probably might have to cut this for the next kind of final edit. Okay. Now, here's a number to remember, 3.5, and that is not your INR target. That is actually the lowest point at which INR should be for symptoms starting to relent. And I actually want to read something from one of Prof. Hughes' books from the antiphospholipid syndrome guide for students, just to illustrate this point and really hammer it home. Sadly, warfarin comes up against two widely held opinions. Firstly, that warfarin, the poison, is toxic. Unfortunately, apart from its effect as an anticoagulant, side effects are rare. And secondly, in stroke, there is often still more of a fear of bleeding than of clotting. The danger in Hughes syndrome being one of clotting. Another problem concerns INR levels. Many patients with Hughes syndrome require a higher INR than the average anticoagulant clinic patient, and this is often especially the case with some of the neurological problems where INR levels of 3 to 5 or to 4 may be required. It is not uncommon for patients with Hughes syndrome to know their INR. The headaches, dizziness, memory difficulties returning, for example, when the INR falls below, say, 3.5. Patients come to clinic, for example, with a label of unresponsive to warfarin, and in many cases at Lancet, the INR results show the INR often not hitting the 3 level. So there you go. Now, to test for antiphospholipid syndrome, there's three main tests, which are anticardiolipin antibodies, anti-beta-2 GP1s, which are a subset of the anticardiolipin antibodies, but it might actually identify more people. And then you got lupus anticoagulant, and lupus anticoagulant is also associated with the worst prognosis of all three. The more you have, the worse the prognosis, but having lupus anticoagulant is particularly bad. And also it can cause false results when you use handheld INR readings. If you want to look deeper into it, there's antiphosphatidylserine, antiperturbin antibodies, and there's even a couple of more which are associated. I'm not going to get into that. But importantly, this is there exists seronegative antiphospholipid syndrome, like in any other hematological disease, which reminds us that antiphospholipid syndrome is an autoimmune disease, and also reminds us of the epistemology of medicine. When we look for something in medicine, we don't actually find what we look for. We go look for something by finding some other things that tell us that what we are actually looking for is likely to be there. But we don't actually see what we're looking for in nearly all the cases. And that is something that as doctors we too often seem to forget. And it does make a difference to keep that in mind. So I'll get this slide at the end, but just to recap what we've talked about so far. Arterial thrombosis is antiphospholipid syndrome until proven otherwise. And any peripheral vascular disease under 40, it's antiphospholipid until proven otherwise. Any thrombotic MI under 40, it's antiphospholipid until proven otherwise. Any young stroke, in the absence of, say, malignant hypertension or massive cocaine use, it's antiphospholipid syndrome. Also worth keeping in your differential